It's time for another warm-up. Let's get going. What are the clinical uses for each of the following anti-muscarinic drugs? The first one we have here is ipratropium. So this is used to treat COPD and asthma. It's often used in combination with albuterol, sometimes on its own. Next we have atropine, homatropine, and tropicamide. So these are used to dilate the pupils and they cause mydriasis. So they're also going to cause psychoplegia as well, or paralysis of the auxiliary eye muscles. Next we have benztropine. This is used to treat Parkinson's disease. Scopolamine, so this is a patch often used, you put behind the ear, used for motion sickness. It can also be used for end-of-life care to reduce secretions. So a terminally ill patient who is constantly choking on their own oral secretions, you can use this. Next, which receptors use a GS protein? So that's going to be a beta-1, beta-2, vasopressin 2, histamine 2, and dopamine 1. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to look at a bunch of disorders that may affect the joints somewhat, but largely these affect other parts of the body, and in some cases the entire body. So these are systemic rheumatologic disorders. We'll start with systemic lupus erythematosus, or SLE. The vast majority of lupus patients are young to middle-aged women, and lupus is more common in black women. Lupus is a disease with a zillion possible presentations. Patients can have nonspecific systemic symptoms such as fatigue, weight loss, fever. Patients can have lymphadenopathy in the neck, the axilla, or the groin. And they can have some splenomegaly as well. Patients can acquire a type of endocarditis called Liebman-Sachs endocarditis, where they have sterile vegetations on their heart valves. So these look like the vegetations of bacterial endocarditis, but nothing grows on culture. They're sterile vegetations. So it may help you to remember that patients with SLE can get LSE, or Liebman-Sachs endocarditis. Lupus can also cause Raynaud phenomenon, where you have vasospasm in the fingers due to exposure to cold temperature. We'll discuss Raynaud phenomenon in cardiology as well. So lupus can cause a lot of very different clinical presentations. One person's lupus can look completely different from someone else's lupus. Let's turn to the study guide to look at the diagnostic criteria. There are 11 diagnostic criteria for lupus, and you have to have at least 4 out of 11 to make the diagnosis. A lupus patient does not have to have all 4 at the same time, but at least 4 at some point during the course of the disease. We've grouped these criteria into skin disorders, inflammatory disorders, and then various organ system disorders. What are the skin findings associated with lupus? There could be a malar rash, described as a butterfly rash on the cheeks. There could be a discoid rash, which are discrete raised erythematous lesions with some scaling, usually on the face or scalp or ears. And they can cause atrophic scarring. So this is what the music artist Seal has on his face, scars left over from discoid lupus. That fact may help you remember what the lesions look like. You can have photosensitivity. You can have painless oral ulcers. Very important, these aren't painful aphthous ulcers. These are painless oral ulcers. So make sure you recognize the distinction. For the inflammatory conditions associated with lupus, you can have arthritis, which is a non-erosive, non-destructive arthritis at least 2 joints. Osteoarthritis would be an example of a destructive, erosive arthritis, but this is a non-erosive arthritis. And you need at least 2 joints with non-erosive arthritis in diagnosing lupus. Serositis is inflammation of the serosa, such as pleuritis or pericarditis. And then positive ANA is one of the inflammatory criteria. ANA is pretty nonspecific though. And although ANA is one of the diagnostic criteria, the patient doesn't have to have a positive ANA to make the diagnosis of lupus. And more importantly, just because a patient has a positive ANA doesn't mean that the patient definitely has lupus either. But it is one of the criteria. And we're talking about significantly positive ANA, like 1 to 160 or 1 to 320. Patients sometimes want to get all excited about an ANA titer of 1 to 4 or 1 to 8, but that's very common and very nonspecific. Then the last group of criteria are the organ system disorders. Proteinuria or cellular cast would indicate renal disease or lupus nephritis. We'll come back to lupus-associated renal disease again in a moment. Neurologic disorders include seizures and psychosis. Hematologic disorders include hemolytic anemia, leukopenia, lymphopenia, and thrombocytopenia. And then immune disorders as indicated by autoimmune disease such as positive anti-phospholipid antibodies, anti-double-stranded DNA antibodies, anti-Smith antibodies, or a false positive VDRL. So let's backtrack for a second and talk about lupus nephritis a little bit more. Renal failure from progressive lupus nephritis is one of the leading causes of death in lupus patients. In lupus nephritis, you can see wire loop lesions in the kidney histologically and deposition of immune complexes. So it might help you to remember the phrase wire lupus. So lupus has wire loops or wire lupus, which is basically thickening of the capillary walls. What lab tests do we use to diagnose lupus? We mentioned ANA, or anti-nuclear antibodies. ANA is sensitive, but not very specific for lupus. It's a decent screening test for lupus. Almost all patients with lupus have a positive ANA, but again, it's not necessary to make the diagnosis. If the ANA is negative, you're much less likely to have lupus. If it's positive, it could be lupus, or it could be something else. So what else has a positive ANA? Sjogren's syndrome, scleroderma, polymyositis, dermatomyositis, rheumatoid arthritis, juvenile idiopathic arthritis, and mixed connective tissue disease can all be associated with a positive ANA. So again, ANA is sensitive but not specific. We mentioned anti-double-stranded DNA antibody. That's much more specific for lupus, and especially for the renal disease associated with lupus. There are also anti-Smith antibodies, which are also very specific for lupus. Anti-histone antibodies are associated with drug-induced lupus in addition to systemic lupus. You can have anti-histone antibodies with regular lupus that's not drug-induced, but classically we think of it as drug-induced lupus. So for the purposes of your exam, you can think of anti-histone antibodies as being a clue for drug-induced lupus. Then what are the drugs associated with drug-induced lupus? The mnemonic is SHIP, S-H-I-P-P, for sulfonamides, hydralazine, isoniazid, phenytoin, and procainamide. A couple more labs that you might check in a lupus patient. There are anti-phospholipid antibodies, which cross-react with the cardiolipin used in lab tests. So you'll also hear these called anti-cardiolipin antibodies. You can have positive anti-phospholipid antibodies or positive anti-cardiolipin antibodies without having lupus, but they are commonly associated with lupus. And these antibodies cause coagulation disorders, resulting in hypercoagulability. Then the other immunologic marker you should know is decreased serum C3 and C4. Lupus can result in low levels of complement, causing some immunodeficiency and increasing the risk of severe infections. One last thing to mention briefly about lupus is the treatment. Steroids are commonly used, NSAIDs are commonly used, hydroxychloroquine is a drug that you might want to know, often used to treat lupus. And for advanced lupus, especially if there's some lupus nephritis, cyclophosphamide can be useful. So glucocorticoids, NSAIDs, hydroxychloroquine, and cyclophosphamides are the drugs I want you to know that are commonly used to treat lupus. Let's talk about scleroderma next. It's also known as progressive systemic sclerosis. Scleroderma is a disease where you have fibrosis and excess collagen deposition throughout the body, not just the skin, but throughout the body. It's not really an inflammatory disease at all, it's a bulking disease. Because you have so much fibrosis and collagen that's going to interfere with the normal function of a lot of different tissues. So you get sclerosis and scarring of the skin, so that skin becomes tight and sometimes shiny with no wrinkles. The tightening of the skin on the fingers can cause contraction of the fingers and sometimes ulcers on the fingers. So these patients might have trouble extending their fingers and possibly difficulty gripping their fingers also. Then beyond the skin, you can involve lots of other tissues. There are two types of scleroderma that I want you to know for your test: diffuse scleroderma and crest scleroderma. Diffuse scleroderma is characterized by diffuse widespread sclerosis, which progresses rapidly and tends to involve the visceral organs fairly early. And diffuse scleroderma is associated with antibodies against DNA topoisomerase 1. Another name for those antibodies is anti-SCL70 antibodies. SCL is for scleroderma. You need to remember both of those names, anti-DNA topoisomerase 1 antibodies and anti-SCL70. And then the second major form of scleroderma is Crest syndrome, which is a different variant of scleroderma. C in Crest is for calcinosis or subepithelial calcium deposits. R is for Raynaud phenomenon. E is for esophageal dysmotility. S is for sclerodactyly or scarring of the fingers, and T is for telangiectasias. Again, calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias. With Crest syndrome, there is limited skin involvement. It can affect the fingers and face in terms of skin involvement, but you also have these other problems we just mentioned. The Crest form is generally more benign, there's less visceral involvement, and it progresses less rapidly. And Crest syndrome is associated with anti-centromere antibodies. So remember C for centromere and C for Crest scleroderma. Let's move on to Sjogren's syndrome. First, the basics. Sjogren's syndrome consists of a triad of dry eyes called xerophthalmia, dry mouth called xerostomia, and disease-defining antibodies including anti-Rho, also called anti-SSA, and or anti-LAW, also called anti-SSB. There are other autoimmune diseases that have the sicca symptoms of xerophthalmia, also known as keratoconjunctivitis sicca, and xerostomia, but only patients with Sjogren's syndrome have the disease-defining antibodies I just mentioned. Additionally, the majority of Sjogren patients also have arthralgias or arthritis as an extraglandular manifestation. All right, now let's discuss Sjogren's syndrome in a little more detail. The problem in Sjogren's syndrome is autoimmunity. Most patients with Sjogren are women between the ages of 50 and 60. The immune system attacks the exocrine glands, particularly the lacrimal and salivary glands, resulting in a lymphocytic infiltration of B and T lymphocytes. As a result of the lacrimal gland infiltration, patients have dry eyes, or again, the dry eyes referred to as xerophthalmia, possibly conjunctivitis, and possibly a sensation of sand in the eyes. As a result of the salivary gland infiltration, patients often have bilateral parotid enlargement and an excessively dry mouth that may cause dysphagia, or an inability to speak more than a few sentences, or an increase in dental caries is a huge clinical clue. Other exocrine glands may be targeted by the disease, resulting in nasal dryness, dry throat, known as xerotrachea, and consequently chronic bronchitis. Additionally, vaginal dryness and dyspareunia and or reflux esophagitis. To help you remember the constellation of symptoms, dry eyes, dry mouth, and usually arthritis associated with Sjogren's syndrome, you might use the mnemonic for Sjogren, which is can't see, can't spit, can't climb up shit. So maybe that's helpful. A few other things to know about Sjogren's syndrome. The definitive way to diagnose Sjogren's syndrome is by a biopsy of the lip to examine the minor salivary glands found there. I mentioned the disease is associated with an excessive lymphoid infiltrate. Associated with this is an increased risk of B-cell lymphoma. I mentioned arthralgias and arthritis as possible extraglandular manifestations. There are other possible extraglandular manifestations associated with Sjogren's syndrome, such as Raynaud phenomenon, but those are beyond the scope of your exam. All right, let's go over a few muscle disorders next, starting with muscular dystrophy. There's Duchenne muscular dystrophy and Becker muscular dystrophy. Duchenne muscular dystrophy is caused by an X-linked frameshift mutation that causes a deletion of the dystrophin gene, leading to accelerated muscle breakdown. The dystrophin gene is the longest known human gene, which makes it kind of a setup for spontaneous mutations. The dystrophin protein helps to anchor muscle fibers, particularly in the skeletal and cardiac muscle. Without dystrophin, you have accelerated muscle breakdown, and that causes elevated creatine kinase, abbreviated CK. What is CK a marker for? It's a marker for muscle breakdown. As muscle cells become inflamed or injured, they die and they spill their contents, including creatine kinase. Duchenne muscular dystrophy presents very early in life, before age 5, starting with weakness in the pelvic girdle muscles, which eventually progresses superiorly. Kids with Duchenne muscular dystrophy get pseudohypertrophy of the calf muscles due to fibrofatty replacement in those tissues. That's why it's called pseudo-hypertrophy. It's not true muscle hypertrophy. The calves look bigger, but it's replacement of muscle with the fibrofatty tissue that's making the muscle look bigger. Another classic sign of Duchenne muscular dystrophy is called Gower's maneuver. These kids can't stand up from a squatting position because their proximal leg muscles are weak. So they get up off the floor by using their arms, and they walk their hands from the floor to their feet and then up their legs to stand up. You can find a lot of different YouTube videos that demonstrate Gower's maneuver if you've never seen it. Then Becker muscular dystrophy is due to an in-frame deletion that results in a mutated dystrophin gene instead of the deleted dystrophin gene that we saw with Duchenne muscular dystrophy. So Becker is less severe than Duchenne, and there's later onset in adolescence or early adulthood instead of before age 5. For example, patients with Duchenne muscular dystrophy are typically in a wheelchair by age 12, while patients with Becker muscular dystrophy are able to walk beyond age 15. Next, we're going to talk about polymyalgia rheumatica. And since it's called polymyalgia, you would think this is a muscle disease, but it's really not. It's a type of joint pain. There's joint pain and stiffness in the proximal joints, the hips, the shoulder girdle, and maybe the neck. And then polymyalgia rheumatica is a systemic disease, so it's often associated with malaise, weight loss, and fever. But in polymyalgia rheumatica, there is no muscle weakness. So that can help you distinguish polymyalgia rheumatica from polymyositis. The average age of onset of polymyalgia rheumatica is age 70, and it's 2 or 3 times more common in women. So if they give you a little old lady with proximal joint pain and stiffness, think about polymyalgia rheumatica. And it's sometimes associated with temporal arteritis, also called giant cell arteritis. Temporal arteritis is covered in the cardiovascular section. And we'll talk about different types of vasculitides in the cardiovascular section as well. With polymyalgia rheumatica, you have elevated ESR and normal creatine kinase. Again, this is not a muscle problem, so creatine kinase is normal, indicating no muscle disease. The treatment is steroids such as prednisone. You give them just a small amount of prednisone and they miraculously feel much better. Now, sometimes people will get polymyalgia mixed up with polymyositis, but polymyositis is really a disease of muscles. It's a muscle inflammation. Myo is muscle and itis is inflammation. So polymyositis is an inflammatory muscle disease. Muscle diseases typically affect the proximal muscles more severely because those are your big muscles, and more muscle means more opportunity for pathology and muscle disease. So that's one of the hallmarks of muscle disease, proximal muscle weakness. Distal weakness tends to be caused by neurologic disease because the neurons have to travel a longer way from the brain to the distal parts of the limbs. So they're more susceptible to injury because of that long distance. So proximal muscle weakness is often due to a muscle problem, and distal weakness is often due to a neurologic problem. With polymyositis, there is a CD8 positive cytotoxic T cell induced injury to the muscle fibers, often involving the shoulders and the pelvic girdle muscles, again, proximal muscles. To make the diagnosis, you might use a muscle biopsy to look for evidence of inflammation. Labs will show elevated CK because of muscle inflammation and muscle breakdown. So with polymyalgia rheumatica, we said the CK was normal, but with polymyositis, the CK is elevated. Another useful lab marker is elevated aldolase, which is another enzyme released from inflamed muscle. And in polymyositis, you have positive ANA and positive anti-Jo1 antibodies. Dermatomyositis is similar to polymyositis, but in addition to the muscle inflammation, you also have a skin involvement. There are several interesting skin manifestations associated with dermatomyositis, including a malar rash, like we saw with lupus, purple heliotrope rash on the eyelids, Gottron's papules, which are reddish, scaly papules on the knuckles and maybe on the elbows and the knees. There might be something called a shawl sign, where the rash is over the shoulders like a shawl draped over the shoulders, or a V sign, where it's in the anterior chest in a V shape, like a V-necked shirt. there might be something called mechanic's hands, which is where the fingers are rough and cracked. Here you see those changes on the foot, and the skin can even look dirty sometimes, like you've been working on a car. So if you see one of these plus muscle weakness, think about dermatomyositis. There may be a little mild muscle soreness, but it's primarily muscle weakness. Polymyositis and dermatomyositis also carry an increased risk of malignancy. This is a little controversial, but about 15% of patients with dermatomyositis will either be diagnosed with a malignancy at the same time or will be found to have a malignancy down the road. Again, the instances of malignancy are 15% for dermatomyositis and about 10% for polymyositis. Then one last disease to cover is fibromyalgia. Fibromyalgia is a disease of increased sensitivity to pain, sort of resetting the pain threshold, so it causes excess muscle tenderness in 11 out of 18 particular sites. So there are 18 specific areas called trigger points, 9 on each side of the body. The classic way to diagnose fibromyalgia is to palpate these trigger points where the patient might be tender with a specified amount of pressure, and if they are tender in at least 11 of those 18 sites, you can make the diagnosis of fibromyalgia. In addition to muscle tenderness, patients may also have chronic generalized pain, fatigue, sleep disturbances, headache, cognitive difficulty, and or mood disturbances as comorbidities. And at least 30% of these patients also have depression or anxiety. Then for the pharmacological treatment of fibromyalgia, there are 2 drugs that the FDA has approved specifically for fibromyalgia. There's pregabalin, which is an anticonvulsant mainly used for neuropathic pain, and there's milnacipran, which is an SNRI, a serotonin norepinephrine reuptake inhibitor. But outside of the official FDA-approved treatments, some of the older treatments include amitriptyline, a tricyclic antidepressant, low-dose analgesics such as acetaminophen or NSAIDs, and fluoxetine or Prozac. I try to avoid opioids because patients with fibromyalgia have chronic pain, and once you start them on narcotics, typically they're going to be on them forever and develop tolerance, and then they keep coming back for more opioids and wanting more and more. So narcotic pain meds are just not the best choice for treating fibromyalgia. And then non-pharmacological treatment is very important, including reassurance that they don't have lupus or some type of crippling arthritis. Educate them about the diagnosis of fibromyalgia. Stretching exercises are very important. Sleep is a huge problem for patients with fibromyalgia. They're always tired, they don't sleep well, and the lack of sleep makes them hurt. And when they hurt, they don't sleep well. Sometimes we'll use sedating antidepressants such as trazodone to help them sleep, and trazodone may also help their depression. And then relaxation techniques and stress reduction are important as well. So that's it for systemic rheumatologic diseases and muscle disorders. Now you're ready for the end-of-session quiz and the rapid-fire facts. So work through those, and then we'll go through those answers together. First question, a patient presents with photosensitivity, arthritis, hemolytic anemia, and recurrent oral ulcers. What's the most likely diagnosis? So this constellation of symptoms is most likely lupus. What drugs are known for causing drug-induced lupus? Remember the mnemonic SHIP, S-H-I-P-P. Sulfonamides, hydralazine, isoniazid, phenytoin, and procainamide. What are some of the characteristics of polymyositis that distinguish it from polymyalgia rheumatica? In polymyositis, there is muscle weakness as well as elevated CK, aldolase, ANA, and anti-Jo1. In polymyalgia rheumatica, there is joint pain but no muscle pain or weakness. And since there is no muscle inflammation, CK and aldolase will be normal. And then there's a list of rapid-fire facts. Let's go through those. Anti-Smith and anti-double-stranded DNA antibodies are suggestive of lupus. Anti-histone antibodies are seen in drug-induced lupus. Anti-centromere antibodies are seen in crest scleroderma. Anti-topoisomerase antibodies are seen in diffuse systemic scleroderma. Anti-Jo antibodies are seen in polymyositis. Anti-Rho antibodies, also known as anti-SSA antibodies, are seen in Sjogren's syndrome. The triad of arthritis, dry mouth, and dry eyes characterize Sjogren's syndrome. All right, that's it for this video. See you next time.